Good afternoon. Can people hear me? This is Beth Edgerton. Great. Thank you again for everyone's patience. The exciting news is we have many attendees on, so we're using a different format than we usually use. So again, thank you for your patience. Welcome this afternoon to our continuing series, EMSC Opportunities for Enhancing Pediatric Emergency Care, Pediatric Readiness Data, an opportunity to improve quality of care in your emergency department. My name is Dr. Beth Edgerton, and I'm the Division Director at HRSA's Maternal Child Health Bureau in the Division of Child, Adolescent, and Family Health, where our EMS for Children program is housed. We are excited to have three presenters today, Dr. Macias, Dr. Remick, and Ms. Evelyn Lyons present to us. Our objectives for today, as a result of having participated in this webinar, our attendees will be able to define quality improvement and its scope and impact in pediatric emergency care, distinguish quality assurance from quality improvement, list critical components of the quality improvement process, illustrate via case presentations a pediatric emergency quality improvement opportunity, and finally identify potential quality improvement initiatives via pediatric readiness data. Again, the background for today's webinar is our National Pediatric Readiness Project, which is a multi-phase quality improvement initiative. Again, as many of you know, that we involved emergency departments across the United States who participated in an assessment. We had over 4,000 emergency departments participate in this 2013 assessment. And again, we will be discussing opportunities in which people can follow up on these results. Today's session does have credit associated with it. We have credit from the Indian Health Service for nursing continuing education contact hours and physician contact hours. Please remember to select the appropriate type of continuing education you are seeking on your evaluation. Again, accreditation does not apply solely to educational activity. It does not imply approval or endorsement of any commercial product by any of our accreditation bodies. Again, if people could put their phone on mute, that would be great. And finally, all of our faculty have completed a faculty disclosure statement. Regarding continuing education evaluation certificate, at the end of this presentation, you will be given a website to go to complete an evaluation and receive your continuing education. So I'd like to get started with today's presentation. As I mentioned, we have three experts in the field that will be sharing their insights with you. I'm going to go ahead and introduce you all three speakers to provide continuity to our presentation. And then at the end, we will address questions. So if you have a question that comes up during the presentation, please type it in the chat room, and we will keep a tally of it and then have our speakers address it at the end of this presentation. First, I'd like to introduce Dr. Charles Macias, who's boarded in pediatrics and pediatric emergency medicine and completed a clinical research fellowship. He is a graduate of Stanford University, Southwestern Medical School, and the University of Texas School of Public Health. He is currently the Chief of Clinical Systems, and he's a mouthful, Chief Clinical Systems Integration Officer and the Director of the Center for Clinical Effectiveness at the Texas Children's Hospital and Baylor College of Medicine. Dr. Kate Remick completed her residency and chief residency in pediatrics at Washington University and a fellowship in both pediatric emergency medicine and emergency medical services at Harbor-UCLA Medical Center. She was the co-primary investigator of the California Pediatric Readiness Project and is one of our core investigators for the National Pediatric Readiness Project. And finally, Ms. Evelyn Lyons is the manager and co-principal investigator of the Illinois Emergency Medical Services for Children program at the Illinois Department of Public Health. She has coordinated the Illinois EMSC program since 1994, so brings a lot of expertise to our discussion today. So we will start with Dr. Macias, and give me 1 moment. And there you go, Dr. Macias. I think you are ready to go.
Thank you, Beth. As Beth mentioned, we have a number of defined objectives for the next hour or so, but I wanted to walk you through the course of the discussion today. I'll start off with a definition of quality improvement and hopefully convince you that the scope of quality improvement and improvement science is very relevant to the practice of pediatric emergency care. We'll distinguish quality assurance from quality improvement, and we'll talk about some of the critical components, some of the tenets of quality improvement and the quality improvement process. We'll then pass the conversation over to Dr. Kate Remick, who will give you a quick introduction to the National Pediatric Readiness Project to really illustrate how a national framework for measurement of quality in hospital emergency departments can be used to take these core concepts into a more national practical framework. That will give us an opportunity then to hear from Evelyn Lyons, who will illustrate via case presentation some of the pediatric emergency quality improvement opportunities that she and her collaborators in the state of Illinois have taken advantage of and have been able to demonstrate great outcomes for. We'll then close back with Dr. Kate Remick, who will talk a little bit about how these quality improvement tenets that I described and that Evelyn Lyons has illustrated can be relevant to the National Pediatric Readiness Project, and also close with some potential quality improvement strategies, and particularly engagement with the toolkit for the National Pediatric Readiness Project. So I want to start by convincing you that quality improvement is important in pediatric emergency care. Pediatric emergency care in the United States is a very significant part of healthcare delivery. In fact, children account for about 25 million visits to emergency departments every year, which is about 25% of all visits. Interestingly, 80 to 90% of those patients are cared for in general EDs. They may not be emergency departments that are geared for a constant barrage of pediatric emergencies. So 50% of those emergency departments may see fewer than 10 pediatric patients per day. Less than 5% of those patients may require tertiary care. All of this can mean a very limited experience with critically ill children. So put that into the context of where our national healthcare system is, and we can look to the Institute of Medicine's description of quality improvement and pediatric emergency care, and that's illustrated in 3 publications: hospital-based emergency care, emergency medical services at the crossroads, and the one most pertinent to pediatric emergency care for children, growing pains. In it, we illustrated weaknesses in the healthcare system, and in particular, gaps in quality improvement, so much so that in the week following the publication of these 3 documents, the Washington Post published the following: that emergency medical care in the United States is on the verge of collapse. That as a system, it provides care of variable and often unknown quality. Certainly strong words, but we have a framework for understanding how one might look at quality. And that's also provided by the Institute of Medicine in Crossing the Quality Chasm. In it, they describe that care should be safe. It should avoid injuries to the patients and to their families from care that's intended to help them. It should be equitable. It should not vary because of personal characteristics. It should be patient-centered, that is, respectful and responsive to individual and family patient preferences, needs, and values. It should be timely, reducing waits and potentially harmful delays to those who receive and to those who deliver care. It should be efficient, avoiding waste in equipment, supplies, ideas, and energy. And it should be effective, that the services based on scientific knowledge, that is, best practice, best evidence, should be provided to all who could benefit from it. 2 most recently added are access to care and a care continuation model. So what has this actually meant for the outcomes that we have seen? Well, in To Err is Human, 2 studies were cited, both done in the late 80s and early 90s, describing from anywhere from 44,000 to 98,000 deaths annually in the U.S. due to preventable error. This number is often cited and has led to quite a bit of media attention. But most interestingly, publications fairly recently, this published in ProPublica.org, citing the Journal of Patient Safety, really estimates that those number of deaths may actually be much greater, and that we may actually be looking at anywhere from 210,000 to 440,000 each year who go to hospitals and suffer some type of preventable harm that contributes to their death. An astounding number. And in fact, Health Grades in 2007 to 2009 cited a study that described over $7 billion in excess costs attributable to these medical errors. So the impact to our healthcare system, the impact to the hospitals is great. Is this acceptable? Is this what we strive for in pediatric emergency medicine? Well, the reality is no. Medical error and risk in emergency medicine settings is high. Why? Because chaotic environments create latent environments of risk. We have no prior relationships with families. These settings are often high acuity settings, often involving resuscitation. Shift work and handoffs provide other latent opportunities or other latent environments of risk. Pediatrics itself, by very nature, involves weight-based medications and treatments, other areas primed for error. And the very developmental state of our patients means we can't expect the same thing out of every patient. So there's certainly a need for pediatric quality improvement in healthcare infrastructures. Well, all of this has caused quite a bit of public outcry. And in fact, when we look at changes in our healthcare system, when we look at what we as consumers, as deliverers of care, are really seeking, we're really seeking value. And in its simplest form, the Porter equation describes value as quality over cost. Now, there's certainly a limited ability to cut costs in our current paradigm for delivering care. We seem to feel that we've done about all we can do to cut costs or eliminate waste here and there. So in an environment where cost at best is marginally increasing, healthcare must markedly improve quality to get value out of the system. So why does any of this matter? Let me give you a parallel example. So this is a real randomized clinical trial of treatment of hypertension on the job site. So, of course, an adult study, and this was in Eastern Ontario at a steel mill, where patients were either started on antihypertensive at the job site, or they were referred to a primary care physician for initiation of therapy. What the investigators found was that there was no difference in compliance between the groups, but when exploring factors relating to the therapy, they revealed specific determinants of the clinical decision to treat some, but not other hypertensive patients. And those factors were the following four: the level of diastolic blood pressure, number two, the patient's age, number four, the amount of target organ damage. So I'm monitoring here our responses, but I want to hear your thoughts on what you think number three is. So if you're a renal specialist, don't want you to answer, but for the rest of the audience, what do you think was the third most common reason for the determinant for why a patient would be started on the job site versus being started in the clinical office? So please respond by typing into the chat box in the right side. So gender is one example. I often hear that. No access to the primary care physician office. Relative kidney function. It's a good one. Ethnicity. Patient weight. All factors relating to the patient. Cost. Education level of the patient. Age of the patient. Potentially insurance status. And I'm going to stop there because I'm going to reveal to you the real answer. And the answer that they found was the year the physician graduated from medical school. So why is that important? Because wide variations in practice often have nothing to do with differences among patients, but differences amongst providers and differences amongst healthcare infrastructure workers. So these variations in clinical practices can be improved by minimizing variation in beliefs. What do we think is the right thing to do? Variation in interpretation of evidence. We hear a study, we know of something, how do we interpret what we should do from it? And variation in response when evidence is lacking. So despite the fact that over 600,000 publications are created each year in scientific journals, in the world of pediatrics, it has been said that anywhere from 5 to 10% of all clinical questions asked don't have evidence behind what we can answer. So that leaves us in a quandary for how we minimize variation in a world that needs more standardization of an approach. Is that true in all pediatric care models? Well, whether you're looking at diseases like acute asthma, periorbital cellulitis, retropharyngeal abscess, whether you're looking at populations in our neighbors to the north in Canada, in state, in the FIS database of the Children's Hospital Association, in the kids data held by HRQ, whether you look in a plethora of different sources for studies cited or in a number of different variables themselves cited, you will see that there is large variation in pediatric care delivery, whether it's hospital-based, whether it's office-based. All of it makes it challenging because when you have those variations in delivery, you have variations in their outcomes. So I want to take a moment then to look at some of the potential solutions. For many years, we heard the concept of quality assurance. That quality assurance would assure the outcomes that we're attempting to achieve will provide the answers to our healthcare woes. And the reality is, if you look at this statistically, I'm going to illustrate for you that if you see on the x-axis, everything to the green represents excellent outcomes, where each box could represent some number, and for purposes of discussion, we'll say each box represents 100 cases per year, and you have this normal distribution. You have these outliers to the left and to the right with this distribution where there's lots of poor outcomes on the right side. If you focus on the outliers, as does traditional quality assurance, you're looking at a prescriptive approach to eliminating those cases. And so at best, you're moving one standard deviation, 1.96 of that standard deviation, so 2.5% of that total population of those boxes, to move them into an acceptable area. The problem with that approach is that the impact is minimal. You've exerted quite a bit of effort to improving care, and you've had a minimal impact on culture from the prescriptive approach. In fact, in many cases, you may be pushing against culture in the way that that strategy is delivered. In a quality improvement model, we might take that same distribution, but instead of focusing on getting rid of the outliers, we're improving quality by changing the infrastructure. We're looking at improving the majority of cases, not getting rid of the minority of outcomes. So my strategies then may be using best evidence, using quality improvement methodologies through evidence-based practice clinical standards, targeting the inlier variation, not the outlier variation. I've changed the entire infrastructure. What that does then is it helps me move the entire curve to the left, and I no longer care as much about the outliers because now the vast bulk of my population is performing in the excellent outcomes area. So this results in a better outcome for the population, and now your hospital is impacting the majority of your target population rather than being prescriptive to the few outliers. So when we encapsulate all of this quality improvement approach and drill down to what is it that I hope to define by quality improvement, I can look at quality improvement by the following definition: the degree to which health services for individuals and populations increase the likelihood of desired health outcomes and are consistent with current professional knowledge. So two components to that definition. The first is the likelihood of desired health outcomes, recognizing that in a system that measures our outcome, it is only through the outcomes that we can truly define high quality. And if we set off to drive a quality initiative project without measurement and without a definition for outcomes, I'll never know when I've achieved what I've attempted to achieve. So quality and outcomes are interrelated. The second half of that definition was that quality means that what you're implementing is consistent with current professional knowledge. And we often think of that as evidence-based practice, but clinical decisioning and clinical expertise in any system really comprises a number of components. It includes patient values and preferences, resource issues and understanding what resources we have, and physician and patient preferences. All of this interdigitates to say evidence alone is not going to drive quality improvement, but understanding how our patients are involved, their families are involved, what physicians, clinicians, nurses view as important, and what resources I have are all part of that. So there are some tenets of quality improvement that extend beyond evidence-based approaches. That quality improvement means there would be proactive rather than reactive approaches to errors and inefficiencies, that safety is a priority, and that errors should be made transparent. And in fact, all data should be made transparent. We should all understand our performance. Needs are anticipated, and that we're focused on building a high reliability organization, that we focus improvements within the boundaries of an infrastructure. We understand what is within our locus of control to be able to change, that we want to minimize wide variations of practice, as I described before, and that we should be changing things centered around the needs of the patients rather than the needs of the provider. So let's take an example of that. So within a model, the model for improvement, I might be defining aims, and I would use the SMART aim approach, that the aim should be specific. There should be a single focus directed at what we're trying to accomplish. It should be measurable. That metric should be quantifiable. It should be actionable. We need to know what the endpoint is and be able to define it. It should be relevant and realistic. The aim should be important to the patients, the providers, and the overall goals of the hospital, the emergency department, and it should be time-bound. We should decide on a period, a short period, not a long period, in which this aim could be accomplished, preferably something like 6 weeks to 3 months. The next step of that quality improvement process then is to define the measurement. Determine how we will assess whether the change would be an improvement or would demonstrate that we have failed to achieve that. There are various approaches that will then allow us to understand what we can leverage. We can take tools like brainstorming, process mapping, identifying key drivers, using fishbone diagrams, cause and effect diagrams, evidence-based practice, best practice illustrations. All of these are outside of the scope of today's discussion, but not outside of the scope of what Kate will refer to in the National Pediatric Readiness Project Toolkit. And then we'll decide on what changes to implement. What are our leverage points? We want to identify what strategies are going to be meaningful and what changes are going to be important, then understand how we might measure those. In our next step, we would then conduct our plan, do, study, act cycles. This is the rapid cycle process improvement part, where our plan is determining how we link this back to our aim and how we'll measure it. We'll create a plan for implementation and a data collection plan. We'll then do what we set out to do, gather data, record our observations. We'll study the outcomes iteratively, compare it to previous performance, and then make a decision. Do we adopt it? Do we need to adapt it? Or do we abandon it? And this is what makes the process iterative. In fact, rare do we expect a single plan, do, study, act cycle to lead to the improvement we've intended, but in fact, it's iterative changes, understanding the results of each study and act piece that ultimately drive us to our improvement. So overall, our roadmap for quality improvement looks like this. We develop our SMART aim, identify our key drivers, and through observing the process, quantifying the inefficiency, and choosing our interventions, we develop our plan, do, study, act cycles, implement the changes, understand when we've achieved the improvement, then we develop our sustainable plan. What this means is that we've got 3 overlying themes, that we're taking the best science, the best evidence that we set out for. We implement our strategies, and then we finalize this with a measurement and analytic component. So with that, I'll pass this on to Dr. Kate Remick.
Great. So let me just take a step back. I just wanted to say thank you so much to Dr. Macias and also to the EMSC program. I appreciate the opportunity to be involved in this next phase of quality improvement as it relates to pediatric readiness. Before I begin, I was asked to disclose that my spouse is a core lab manager for Edwards Life Sciences, but nothing that I will be speaking about today is directly or indirectly related to the work conducted at Edwards. So I wanted to begin with just a few words describing the background and overview of the National Pediatric Readiness Project so that we can then begin to discuss QI related to PEDS Ready data. As many of you know, the 2009 AAP, ASAP, and ENA Joint Policy Statement on Guidelines for the Care of Children in the Emergency Department provides a baseline foundation from which every emergency department in the country should function. The goal is that all hospital emergency departments should be fully prepared to care for ill and/or injured children, and these guidelines are intended for all hospital emergency departments that provide care 24 hours a day, 7 days a week, that are continuously staffed by a physician. In addition, these were supported by 22 organizations, including the Joint Commission, the American Medical Association, and the American Heart Association. Within these guidelines are 7 areas of focus, the first of which is administration and coordination. The simple act of identifying a coordinator for pediatric emergency care, whether that be a physician and/or nurse, is associated with greater overall readiness. These people are responsible for oversight, support, and review of quality activities related to pediatric emergency care. The second area of focus in the guidelines refers to physicians, nurses, and other healthcare providers. We know that many hospitals do not require annual competency evaluations for nurses, physicians, and mid-level providers. Despite the fact that children account for approximately 1/4 of all ED visits, the average ED sees less than 13 children per day, the majority of whom are not critically ill. Thus, critical skills and or knowledge may wane with time, and competency evaluations may help to identify individual gaps and assist with skill retention. Quality improvement, of course, is a third area of focus. Without a QI process that includes pediatric-specific indicators, it is impossible to know the quality of care being delivered to children in your ED. Patient safety includes the presence of processes that minimize the risk of preventable medical errors in children. Such processes include ensuring all children are weighed and that their weights are recorded only in kilograms. Because pediatric dosing is weight-based, simple documentation and additional calculations required to convert pounds to kilograms open up opportunities for unnecessary errors. Other means to maximize pediatric patient safety, as discussed in the guidelines, include recording vital signs on all children, availability of interpreter services 24/7 to ensure adequate histories are taken, and a process to notify physicians of abnormal vital signs, among others. Policies, procedures, and protocols include such policies as disaster preparedness plans that include pediatric-specific needs, inter-facility transfer guidelines and agreements, such that transfers occur accurately and efficiently when needed, family-centered care to ensure better overall understanding of the child's condition and treatment, and a policy for pediatric assessment and reassessment. Support services refers to the availability of laboratory and radiological services to meet the needs of the community served. And finally, equipment, supplies, and medications that must be available in order to provide the necessary care, but require a skilled and knowledgeable provider to be able to deliver that high-quality care. These guidelines were a catalyst for the National Pediatric Readiness Project, the first stage of which was the National Pediatric Readiness Assessment. The goal was to establish a baseline of the nation's capacity to provide pediatric emergency care. The assessment tool was based on the policy guidelines and checklist. Participation was, of course, voluntary and confidential, and over 4,100 emergency departments participated, which represents some 82% of emergency departments across the United States and territories. The National Pediatric Readiness Project was intended as a national quality improvement effort with a focus on pediatric emergency care. Based on both aggregate and individual data, the hope is that these results can be used to drive ongoing local, regional, state, and national quality improvement efforts. Benchmarking is one way to evaluate performance and was used in the National Pediatric Readiness Assessment to facilitate interpretation of individual results. Each participating emergency department was given an overall readiness score, as well as a gap analysis in order to target areas for improvement. A panel of experts weighted the various components and domains of the policy based on what has been shown to be most important in improving a facility's readiness, and those factors perceived as a clinical priority. The assessment tool consisted of 189 total items and 82 scored items. Based on expert consensus, a weighting scheme was developed to create a 100-point scale. Each respondent that completed the assessment received immediate feedback in the form of an overall weighted pediatric readiness score that reflects the 6 major areas of the Joint Policy Statement as seen here. It's important to realize that the score of 100 represents having the essential foundation for being pediatric ready, and that being ready is a dynamic process. If we can benchmark where we are, then we can strive for improvement. It's important to also note that a facility's readiness score is not inclusive of all the components recommended for pediatric readiness. It represents a suggested starting point for emergency departments, and facilities are, of course, encouraged to carefully review the guidelines to develop a comprehensive pediatric readiness program. Benchmarking was accomplished by providing each participating facility with median scores for all other participating emergency departments and according to pediatric patient volume. This way, facilities were able to compare their readiness to similar facilities with like volumes. In 2013, the overall median score based on a 100-point scale was 69. Emergency departments with larger pediatric patient volumes tended to have a greater overall readiness, as demonstrated here. Thus, despite the enormous effort employed in the development of the 2009 guidelines to encourage universal readiness, data obtained through the National Pediatric Readiness Assessment demonstrated numerous opportunities for improvement. These are some of the key results from the National Pediatric Readiness Assessment. Some 55% of participating EDs lacked a quality improvement process that includes pediatric-specific indicators. Without this, it is impossible to know the quality of care we are providing. Many of these other gaps may also be present in your emergency department and should be viewed as possible targets for local quality improvement efforts. For example, it might be reasonable to look at whether adoption of interfacility transfer agreements and guidelines impacts timeliness of care, or to evaluate the frequency of pediatric medication errors before and after creation of a policy to weigh children only in kilograms. While the national results are useful for benchmarking, it's critical to know the deficiencies that are specific to your facility. If your emergency department participated in the assessment, you should have access to your individual score and gap analysis. In this gap analysis, facilities were given the top 3 to 4 areas of focus that would likely have the greatest impact on overall readiness. Additionally, this report summarized facility strengths and weaknesses within the key areas of the assessment. If you did not participate during the national rollout, the assessment tool and scoring document are available at www.pediatricreadiness.org and can be used to identify gaps. It is important to realize that the readiness score is just a snapshot in time. It is created to give a baseline at a point in time and not a final grade. Essential to quality improvement is measuring change to know if what you are doing is working rather than focusing on where you are. Both the baseline assessment and benchmarking can be used for comparison as you work through iterative cycles of change. In response to known deficiencies in pediatric readiness as derived from the assessment, the toolkit was developed. The toolkit is readily accessible via the Pediatric Readiness website and offers immediate access to a wide variety of resources, including information on patient safety, sample policies and procedures as recommended in the guidelines, including interfacility transfer agreements and guidelines, and sample roles and responsibilities for pediatric emergency care coordinators. In addition, the toolkit includes a primer on quality improvement tenets to assist with the development of quality improvement processes at the local level. Any efforts to implement quality improvement processes and or enhance pediatric readiness in the emergency department will be facilitated by the resources available through this toolkit. And I'd now like to turn the webinar over to Evelyn Lyons of Illinois.
Good afternoon, everyone. This part of the presentation will start with an overview of pediatric quality processes and infrastructure within our state. So I'd like to begin with providing some background on our state. Illinois is the 5th most populated state. Based on the 2010 census, we have a population of 12.9 million with a correspondingly large pediatric population. The map graphic on this slide shows our state divided into 11 EMS regions, and historically these regions have provided the geographic infrastructure for our state EMS and trauma programs. So as our EMS for Children program developed and evolved over time, it made sense to incorporate pediatrics into this same regional infrastructure. To give some perspective on this map, approximately 2/3 of our population is located in the northern third of our state, which includes the city of Chicago, and is largely urban-suburban, while the central and southern sectors are primarily rural with urban pockets. So we have a diverse state with varied needs. With respect to hospital resources, we have over 200 hospitals in Illinois. Some are specialty facilities, for example, psychiatric, rehab, or long-term care. 185 are general hospitals that have emergency departments. And of those 185, 60%, or 110, participate in our pediatric facility recognition program. In 1995, we began discussing development of a pediatric facility recognition program. It took us several years to finally roll out the process in 1998, and it was initially a voluntary process and still, for the large part, continues to be primarily voluntary. However, in 2005, it became mandatory for EMS system hospitals, which are the lead hospitals for pre-hospital care within our state. We have over 60 EMS system hospitals, and by 2005, the majority of them were already participating in facility recognition, but this mandate enabled us to get 100% participation by these hospitals. Our facility recognition program is a three-tiered recognition process. The base level is called the Standby Emergency Department Approved for Pediatrics, and there are 13 hospitals recognized at this level. And these hospitals tend to be small community hospitals that typically have a standby emergency department, and some are critical access hospitals that participate. The second level is the Emergency Department Approved for Pediatrics, or EDAP level, which comprises the majority of recognized hospitals. And the highest level, Pediatric Critical Care Center, goes beyond the emergency department and recognizes hospitals with a dedicated pediatric intensive care unit and a number of other pediatric inpatient specialty services and resources. There are 10 hospitals that are recognized at this level. When we look at hospital utilization using state emergency department data from our State Hospital Association, of the 1 million ED annual visits for children age 15 and younger, the majority of those visits, 78%, went to a hospital participating in our facility recognition program. And of the 30,000 visits that required inpatient admission, 94% were admitted to recognized hospitals. This slide outlines key elements that hospitals are required to meet through state regulations. There are requirements related to the facility, such as the PCCC level having a dedicated PICU. Then there are people requirements that need to be met by physicians, mid-level practitioners, and nurses that address such areas as qualifications, continuing education, coverage, and response times. You can see that there are other elements here that match fairly closely with the categories that Kate reviewed and that are outlined in the 2009 AAP document, Guidelines for Care of Children in the Emergency Department, as well as the Pediatric Readiness Assessment. And a key requirement that we have focuses on pediatric quality improvement. Here's a summary of our quality-related requirements. Hospitals that receive recognition from our state health department need to have a multidisciplinary emergency department quality improvement committee or process in place that guides monitoring of specific high-risk indicators as listed here. In addition, there are 2 people-related requirements, a pediatric physician champion and a pediatric quality coordinator. When we began facility recognition, we only had a requirement for a pediatric quality coordinator, which typically tended to be a nurse. But we found that changing practice in emergency departments was limited many times when physicians weren't as integral to the process or if there was lack of buy-in on their part. So now we require that institutions appoint a physician coordinator, or what we call a physician champion, who works together with the pediatric quality coordinator and acts as a change agent. And then the hospital or ED multidisciplinary committee folds in all of the other key disciplines, such as respiratory therapy, pharmacy, and radiology. You can see that the pediatric quality coordinator is responsible for coordinating the data collection and quality review process at their hospital. In addition, all the quality coordinators within a given region, and when I say region, remember back to the map graphic just a few slides ago that outlined our 11 EMS regional infrastructure. Each of those coordinators within a given region, they come together on a quarterly basis and they work on a regional QI project. So in addition to the hospital-required QI monitors, the hospitals also participate in a regional project that they define themselves. This next slide provides some examples of regional QI projects that have been conducted over the years. Working as a region on quality projects has proven to be very beneficial. There's actually a nice spirit of camaraderie among the pediatric quality coordinators, and they seem to rise above any hospital competition. There's always a willingness to share resources during their projects, such as policies, guidelines, and educational materials. And some of their regional projects have actually shown statistically significant improvements, which has been very encouraging, and it really helps them to see the bigger picture of improving care on a large geographic basis. What's also helpful is that each region typically has a tertiary care center that participates in their regional meetings. The communication, networking, and sharing of resources during these meetings benefits all of the involved hospitals, but particularly the smaller hospitals that may lack more sophisticated QI resources. As the state health department that formally designates these hospitals, there's a need to assure ongoing oversight. Hospitals are required to submit a renewal application every 3 years that contains policies, continuing education compliance, and other documents that undergo review. And then on-site visits are scheduled every 4 years. Since there's always turnover in both hospital administration and staff, this helps assure continued compliance with the facility recognition requirements. And although we do see gaps at times, which requires submission of a corrective plan of action, usually compliance is something that the hospitals do take to heart. During the site visit, we asked that the pediatric physician champion and pediatric quality coordinator discuss their quality organizational structure and how quality information is reported both up to the hospital administration as well as across to unit physician and nursing staff. They also need to show us how pediatrics is integrated into their overall quality improvement processes. And for the specific required monitors, we asked them to pull a medical record that corresponds to each of those 4 monitors, such as a pediatric death case and a pediatric interfacility transfer. And then we have them walk us through their QI review process by using case examples. Hospitals also need to have a number of quality-related documents available for us to review during the site visit. We particularly like to see their loop closure processes, which is why we review meeting minutes to see if QI findings, information, and outcomes are being discussed at quality meetings. We like to see how they're sharing that information with staff and also how involved staff are in the QI process. There are resources that help support our quality requirements, and these are the state committee structures that are in place. We have a state EMS for Children advisory board that provides oversight and guidance to all of our EMSC activities, including facility recognition and the quality components. And this board meets on a quarterly basis. Reporting up to the advisory board is our state facility recognition committee and their QI subcommittee, which meet every other month. The facility recognition committee provides oversight to the facility recognition program, the site survey process, and the application requirements. They discuss facility recognition site survey issues, challenges, and they also make change recommendations to the state regulations, such as adding the pediatric physician champion role a few years ago. We recently merged these 2 committees, but over the years, the QI subcommittee was instrumental in developing quality improvement and educational resources, which has really helped provide guidance to the hospitals, especially the smaller hospitals that may lack a strong quality infrastructure and resources. And each of the chairs of the regional committees then report on their regional projects at these meetings, so that serves as even another form of loop closure. So the infrastructure isn't perfect by any means, but it does help convey to the hospitals and regions that they do have a resource that they can go to for guidance when needed, and it does lend to the overall QI efforts, both at the hospital, regional, and state level. In addition to the regional projects, there also have been a few statewide QI projects that we've coordinated over the years. One example that I'm going to detail over the next few slides is a project that looked at pediatric mild traumatic head injury. We looked at this because mild head trauma is common, which made it likely that all hospitals would have some cases to review. There was also more information becoming available at the time that we did this study or this project regarding the use of CT and the high risk associated with potential malignancy. Both the facility recognition and QI committees provided oversight to this project. The various disciplines on these committees work well together and are comprised of emergency and pediatric physicians and nurses, as well as representatives from social services, quality, and data experts. We tried to follow a structured approach to help reinforce key QI tenets with the hospitals and ensure consistency by starting with conduction of a literature search and developing a project aim statement. The project was submitted through the IRB and received an exemption since no protected health information was being collected. We then worked with the hospitals using the Plan, Do, Study, Act process that Dr. Macias discussed earlier. The committees worked together on developing a survey and a monitor tool, and an educational module and resources were also developed that will be reviewed in a few minutes. This particular project took place in 2008 and 2009. As I mentioned previously, we created an aim statement to ensure clarity regarding the focus and scope of the project. This is a simple component that really helps to ensure that everyone is on the same page with the project. During each of the 2 years of the project, hospitals completed a survey. In addition, they conducted 20 medical record reviews of mild head injury cases. 10 of the records needed to be of patients who received a CT scan, while an additional 10 records were to be randomly pulled regardless of diagnostic testing. Here are some of the key components that were included in the survey. Essentially, the survey was intended to obtain baseline information regarding what is currently in place within hospitals regarding their policies, clinical practices, administrative processes, and availability of services. The survey also asked about discharge planning and whether they had QI processes in place related to the head injured patient. This is a screenshot of one question from the survey. It's important to note that both the survey and the monitor tool underwent a pilot process to ensure that we tested them and obtained and incorporated feedback prior to implementation. Key information collected from the medical record tool included such elements as patient history, assessment, reassessment, and discharge elements. During our QI project, a PCARN publication related to identification of children at low risk of clinically important brain injuries after head trauma was pending publication and was released just as our data collection was being completed. Many of you may be familiar with this important prospective study which analyzed over 42,000 children presenting with mild head injury as defined by a GCS scores of 14 or 15. Their aim was to help identify children at low risk of a traumatic brain injury that would likely not need a CT. A useful resource that the publication provided was a decision-making algorithm based on specific clinical indicators and mechanisms of injury that one could follow to identify patients that would be at low risk for a clinically important TBI, and therefore a CT would not be recommended. They outlined two algorithms in the publication, one for children under the age of 2 and those aged 2 and older. So what we did was take those algorithms with PCARN and Dr. Nate Cooperman's permission and review, and we created more user-friendly algorithms that we then distributed to hospitals throughout the state to further support this QI project. As I mentioned, the PCARN study had 2 algorithms based on age. So this slide shows the adapted algorithm for children under the age of 2, and that's identified with the photo of an infant in the top right corner, and the age group is in green font and underlined at the top of the page. Then this next slide shows the reverse side of the algorithm for those aged 2 to 17. So we wanted to ensure that there wasn't any difficulty or confusion with which side was for what age. So this side has a photo of an older child and the age is in blue font and underlined. We printed and laminated these tools and distributed them statewide. And what was really helpful was that the trauma centers within our state rallied behind this effort and supported the use of these algorithms. In conjunction with this project, we also developed an online self-study educational module that included information on appropriate assessment, management, and disposition. And here's a slide from that module. A template set of discharge instructions and return to play guidelines were also developed that hospitals could use or modify for their purposes. So these resources were very helpful for hospitals to better integrate and further ingrain what they learned through this QI project. Here are a few highlights from the survey. The initial survey collected baseline information, and then we attempted to identify changes that took place through this project in the second survey. As you can see, 57% of the hospitals reported taking some type of positive action as a result of participating in the project, with over half taking some action related to their CT scanning practices. There were also some policy changes that were noted. Now, we are aware that there weren't any dramatic changes here, but we have to remember that the length of time that is needed to effect policy and practice changes can be somewhat lengthy. So the survey findings don't take into account and don't reflect those hospitals that had initiated policy revisions but had not yet finalized their revised policies within that year time frame that the second survey was conducted. In regards to the medical record review, there were over 6,800 records reviewed for the two defined age group. It's also important to note that the educational module that was developed and the recommendations from PCARN occurred during the two data collection periods. Some highlights from the medical record review include the following. Findings showed improvement in documentation of key history-taking components. Another finding was that neurological reassessment improved. And we've noted that in other QI projects that we've done, for example, pain, there's usually good initial assessment documentation, but reassessment is where we typically see the gaps and the fall off. So this was a nice finding to see that reassessment improved. And an unexpected finding was that child abuse screening improved. It was great to see this improvement, which, by the way, was a statistically significant improvement. We also have access to our statewide emergency department data, and a separate analysis of that data looked at recognized versus non-recognized hospitals and suggested that hospital participation and facility recognition was associated with lower head CT usage in the ED, and that was using an odds ratio analysis. And lastly, after the project was completed, a number of hospitals wanted to continue monitoring records and work on making improvements in this area. So our data manager was able to develop a retrospective data collection spreadsheet type tool based on the indicators from the PCARN decision rule. And you can review, or you can see that on this slide. Upon entering whether all the indicators were present or not, then the tool identifies whether the record met the risk of a clinically important traumatic brain injury or not. This follow-up tool was very well received, and it supported continuation of this monitor for quite a few hospitals within our state after the state project concluded. So further improvements continued to be made. We really did benefit from the committee structures that assisted with this project, and what was really helpful was that this overall process essentially walked hospitals through the steps of a QI project, and it gave them a structured format to use for their own future QI projects that they could conduct on their own in the future. Thank you, and now I'll turn it back over to Kate.
Thank you so much, Evelyn. That was really an incredible process, and great to have you share that with everyone. So far, we have discussed how quality improvement efforts can lead to more formidable infrastructure and subsequently minimize variation in care through the development of regulatory components as well as a consistent process for delivering care. In addition, we know that in order to be successful, it is essential to maintain an inclusive team construct such that QI team members are drawn from various areas of knowledge and expertise, just as described by Evelyn previously. For example, it would be important to have both a technical expert in quality improvement, but also a clinical leader with a special interest in quality of care. Following an assessment cycle, it's important to provide performance feedback relative to clinical practice guidelines and/or education. QI involves iterative cycles, and initial progress may not be enough to achieve performance goals. To that end, educating stakeholders on overall progress, the importance of quality improvement, and presenting data in a meaningful way can go a long way to garner ongoing support. And finally, collaboration both with other groups within your institution as well as with other emergency departments in a multi-center approach supports benchmarking, helps to engage smaller hospitals that may not have resources or QI capabilities, and ultimately helps to improve the larger system of care through ongoing communication and the identification of areas of excellence and deficiencies that can be targeted for QI efforts. When choosing an area of focus for quality improvement, the typical questions are how are we doing and can we do it better? By that we mean, can we provide care that is more patient-centered, less costly, safer, adheres to standards of care, or is more efficient? The QI process changes the way we think about healthcare delivery by creating a culture of continuous improvement where the patient and the care provided are central. Thus, it's important to choose an area of focus that is most likely to benefit your community. We know from the National Pediatric Readiness Project that having a QI process in the ED that includes pediatric-specific indicators is associated with greater overall pediatric readiness. Certainly, this makes intuitive sense. If one monitors and identifies variation in care, it can then be used to inform and drive an ED to take action. Yet, as previously mentioned, some 55% of hospitals lack a QI plan that includes children. This may have been due at least in part to lack of well-defined pediatric-specific measures of quality of care in the emergency department. Fortunately, through the work of Dr. Evie Alessandrini, 60 pediatric-specific performance measures have been identified through a consensus panel of experts. These were further refined to create the top 15 hospital-based pediatric emergency care performance measures, and such a framework may help to identify areas of focus in your ED. Some of these performance measures overlap with the 2009 guidelines for pediatric readiness, such as measurement of weight in kilograms for patients under 18 years of age, and using a method to identify age-based abnormal pediatric vital signs. Others provide additional suggestions for initial QI efforts, such as door-to-provider time or ED length of stay. Under disease-specific measures, Evelyn Lyons just gave a wonderful example of a QI process to look at the use of head CT in children with minor head trauma. Thus, each of these can be used as a starting point for QI processes. However, it's important to choose a focus, again, that will be beneficial to your community. For a QI project to succeed, an organization must use the knowledge, skills, and experiences as well as perspectives of the wide range of people. Quality improvement requires problem solving, multiple decisions, and an effective solution that involve complex systems. A comprehensive multidisciplinary approach by a quality improvement team is certainly preferred over an individual decision. And the Institute of Healthcare Improvement recommends at minimum that the team include system leadership, technical expertise, and someone with day-to-day leadership. That said, the idea of paired leadership is critical as each individual brings different knowledge and experience to the leadership approach. Certainly, personal attributes also play a role in overall success, and considerations for those might include leaders that are respected, that are team players, that are excellent listeners, good communicators, proven problem solvers, and that are supportive of change and creative. In addition, meetings should be scheduled regularly to ensure ongoing success and rapid cycles for change. Data extraction is an essential to measuring the impact of your efforts. Ideally, whatever performance measure is chosen should be based on guidelines or standards of care when possible. Data points should, of course, be specific in terms of time and other characteristics. In addition, there may be varied sources of information gathering, and it's important to understand the logistics of working with each. A standardized process for data collection is essential for successful quality improvement, and that data must be accurate and consistent in order to generate reliable information. Finally, the frequency of data collection must be decided early on and is based on the SMART aim. For example, initial goals might be to decrease medication error rates by 25% over 3 months following implementation of a process for weighing and recording only in kilograms. Data analysis is the crux of the QI process in that it gives validity to your efforts. During the analysis, it may become clear that there are gaps in the data, either through insufficient capture of necessary elements or poor standardization of the collection method. In addition, data analysis is crucial to quantify the impact of your efforts and demonstrates improvement. This often requires charts and graphs to demonstrate a visible change to stakeholders. Comparing results to baseline values or benchmarking can also be useful. Performance management is the next phase and involves taking your results and moving forward with your organization to set standards for care and establish ongoing system-wide performance measures. Typically, those measures relate to infrastructure, healthcare delivery, and/or outcomes. And the establishment of organizational standards sets a priority for ongoing assessments and reporting on quality measures. And this is key to sustainability. Whether you are in the planning stages of quality improvement or finalizing data to be delivered to hospital leadership, it's helpful to ensure that the message you give to hospital leadership speaks to the more global implications for your institution. While the data may demonstrate clinical measures of improvement, you must consider how the changes implemented may decrease overall cost of care, improve the quality of care delivered, and thus the value of care delivered. Other considerations might be whether the QI process may facilitate accreditation goals and/or regional or community-wide recognition as a leader of high-quality care. Recognition as a patient-centered medical home and/or regional expert has the potential to lessen the burden to families seeking high-quality care in surrounding communities. Regionalized systems of care involve modeling processes for the delivery of high quality of care and the sharing of education and knowledge and minimizing cost. In summary, the common goal is to provide high-quality care to our patients and more specifically to children. But without data and measurement, we have no idea if we are accomplishing this goal. We certainly know there are gaps in readiness, and the logical implication is that the quality of care we're providing may falter in the current setting. Through the QI process, variation becomes transparent and can help drive processes to decrease cost to hospitals and patients and improve overall quality of care. The journey to a healthcare delivery system that consistently provides high quality of care while minimizing cost relies on the three pillars of best practices, performance measurement, and the implementation of standards to ensure the delivery of high quality care. Again, the Pediatric Readiness Toolkit can be used as a source for idea building, and we hope you'll explore it further. At this point, I think we'd be happy to take any questions.
Thank you, Kate. We really appreciate that conclusion and pulling it in. We do have a few questions from the audience, and I didn't know, Kate, if you could expand on your discussion of the quality improvement team. You mentioned a few members, but can you kind of go through maybe how you identify who should be on your team, and does that team remain the same, or do you see turnover, and just kind of a little bit more how that process works?
Certainly, as you're developing a quality improvement team, there will be champions for the quality improvement process, and it is important to have representatives from various areas within the institution, including leadership within the emergency department, potentially from other areas of the hospital, who can help to give ideas and feedback and serve as bouncing off points for ongoing improvement efforts. There may certainly be some changeover with time, but there should be a core set of people who remain the champions for this process. And there may be multiple processes ongoing at a given time, depending on whether there may be multiple champions within your institution. Certainly, if there are other processes, it's important to be able to work together to promote specific areas of focus that are most likely to result in the greatest impact and or change.
Great.
Beth, this is Charles. If I could add one thing to that wonderful description that Kate gave, one of the important tenets of quality improvement is to recognize that quality improvement teams are often built from bottom up rather than top down. We often feel like we're going to make the biggest impact if we have all the highest leaders in an organization involved in the teams, and the reality is that it comes across as prescriptive. And so it's difficult to engage the needs of the workers who truly are interfacing with the patients. So as Kate referred to, it's a few leaders at middle places, but it's a lot of people who engage on a daily basis.
Great. And maybe continuing on the same theme, Evelyn, you can highlight some of the hospitals that participated in your hospital categorization were very small and kind of standby facilities, and how did you engage them in this process and support when they're seeing a few patients versus a children's hospital that sees a lot of patients, so when there is a question, sometimes it's easier to rally around that topic?
I think the provision of resources from both the region as well as at the state level. So I think the committee structures that we have in place at the state level are able to either develop resources or identify resources that can help make things a little bit easier for them. And then also having the regional group come together on a quarterly basis where they can act in a mentoring capacity. They can also share resources so that the smaller hospitals don't have to feel like they're reinventing the wheel or developing something from scratch. They've got some resources, they've got some experts, they've got some other individuals out there that they can reach out to who are working in a community that's fairly similar to theirs and has a better understanding of the patient population that they're seeing as well.
So it sounds like also your state level and regional level quality improvement teams really helped in that continuity in that process?
Yes. The resources that are able to be developed, and then we also, as we come out on site surveys, we try to find out during the site visit if there's things that they're struggling with, if there's suggestions that they have for our program, so that we can take that back and have our state committee structure look at that and see, are there changes that really should be made? Are there things that we can do better? And many times it helps to hear that from the grassroots level, from the hospitals themselves, to see what challenges they're dealing with that maybe we can assist with.
Thank you. And maybe the group can also address if somebody has a facility and they don't necessarily have someone who's an expert in quality improvement, of places they can go. Obviously, Evelyn, you mentioned your teams, but I didn't know if there's other places people can find that expertise.
I think most organizations, Beth, will have some people in compliance departments that are connected with people that are involved in quality improvement. They're not necessarily one and the same, but they have opportunities there. There's also, in terms of education opportunities, through a multitude of websites, including the Institute for Healthcare Improvement. HRQ has a number of resources, and of course, the NPRP toolkit is available as well.
Great. And again, we had some questions, Evelyn, about your tools and resources, and didn't know if those are available to people on the call.
Absolutely. Whatever's easiest. If you'd like to post those along with the slide presentation, I can certainly make those available so they can be put together as a package and people can access them, or I can also provide electronic copy and email those out to folks.
That sounds great. Thank you. We can take maybe one or two other questions if anybody has anything they want to type in the chat box. Again, I would really like to take the opportunity to thank our speakers for all the time and effort that went into their presentation and the comprehensiveness of their overview of this process, and giving us examples to really show that it can be attained by all of us. Again, on the website here, you'll see the link to our evaluation and obtaining continuing education credits. And again, I'd like to close and again thank you for your patience with our technological challenges. No matter how savvy we get, there's always a good one. So we appreciate that goodwill. And again, thank you to our speakers today.